Our plenary session today is a reflection of the 50th anniversary of the Surgeon General's report on smoking, as I mentioned earlier. I also mentioned that I had the honor to attend the wreath-laying ceremony for Dr. Terry at Arlington National Cemetery this summer. Admiral Lushniak and I were talking about that experience. It was a rainy day, overcast, Arlington Cemetery, with all of the history and all of the feelings that come with that. And thinking back on that 50 years of dedicated professionals who said, we are going to change the culture of a nation. We are going to change a deeply embedded aspect of our entire society, and have frankly been very successful in doing so, in what in cultural terms is not a long time. It was an almost surrealistic moment, and I look back on that as a real highlight of my time at AMSUS. So, Admiral, thank you again for allowing me to share that terrific day with you. And now I get to introduce Admiral Boris Lushniak, Acting Surgeon General of the United States, to share his comments and observations with you today.
You hear me? Okay, there we go. Thank you so much, Admiral, and thank you all for being here. AMSUS is one of those meetings that I really enjoy every year. Why? Because it allows us, a little uniformed service, to actually rub elbows with the rich and famous. And at the same time, to see old friends from the international cohort, to be able to connect on a common theme. And for this next hour, what we're going to be discussing is the common theme of tobacco, the common theme of smoking and what it's done in our society, and to be able to inspire, in the midst of this 50th anniversary year, to inspire us all to realize that we still have a mission when it comes to tobacco. And that mission, which is eradication, is attainable. So thank you for being here this morning. As Acting Surgeon General of the United States, what a great year to be in that position. A 50th anniversary year. It allows us to reflect on what went on these past 50 years, but also, as I mentioned, to reaffirm a sense of mission of what lies ahead. Also, as Acting Surgeon General, what are we about? We're about health and wellness. So I'm going to ask everybody to stand up for a second, to stretch, because sitting for too long goes against what we are all about, right? We're about health and fitness and keeping a good fighting force out there. So stretch a little bit. Stretch up, okay? And now turn to your left and say hello. Turn to your right, because it's all about connectivity, folks. Anytime during this lecture or this next 20 minutes, or if you want to stand, just stand and stretch, okay? So anyhow, let's get rolling on this. So I don't have any relevant relationships with industry. I'm not, commercial supporters, no off-label discussions. I'm an officer in the U.S. federal government. Therefore, I have lots of pride and no connectivity or money or investments that are illegal. My work has been supported through my career by the U.S. government, specifically the United States Public Health Service. No, I'm not Navy, but I love my Navy friends. Look closely at the uniforms. You can see what makes us distinct. Can I go back? I actually realized, there we go. So, you want to get inspired? Oftentimes in public health, we get overwhelmed. Now, my little service, 6,800 officers, whose mission is to protect, promote, and advance the health and safety of the nation, stationed in 26 different departments and agencies of the U.S. government. Yes, even within the Department of Defense, within different aspects of the U.S. government. We're a small unknown service. You want to hear the conspiracy theory? Conspiracy theory is this: a small unknown service dedicated to public health has infiltrated the highest levels of the U.S. government. They don't even know we're there, and we're there. Also, I pay tribute to our great cooperative efforts with DOD, specifically in the Ebola issue mentioned by General Horoho earlier. 70 of my officers are the only U.S. government entity actually taking care of patients in West Africa. So at this moment, 70 of my officers are donning and doffing, are there establishing, with the help of DOD, with the help of USAID, a medical care facility, an Ebola treatment unit for healthcare workers in Liberia. You'll hear more about this from my Deputy Surgeon General, who just returned from a 40-plus day deployment as the commander of that unit. Please come to the sessions later on this week. But in the midst of this public health mission that we're on, sometimes we get embroiled with the idea that we're making no progress, that we're going nowhere. Oh, this is so hard to change the way people take care of themselves, to change the way we look at health and wellness. I get inspired, and I recommend that you do this. 1999 Morbidity and Mortality Weekly Report. Make a copy of the article, or just do a PowerPoint slide and put this on your door. It sits on the door of the Acting Surgeon General of the United States. Why? To basically say is we can change the world. And on this list are to take 10 great public health achievements in the last century. Between 1900 and 1999, look at what was achieved. Vaccination. We eradicated a disease, a scourge of the land, smallpox, in that century. Motor vehicle safety. We started with no motor vehicles as a technology. In 1900, it barely existed. By 1999, not only did everyone have a car, did we have an interstate highway system, but we found out that these things were causing mortality and morbidity, and we started doing something about it. Notice the idea of recognition of tobacco as a health hazard, and that's really the theme today. In that century, we changed a nation. So what do we used to have, right? It wasn't that long ago, folks, that in fact our profession, the medical profession, was part of the ploy. More doctors smoke Camels than any other cigarette. 20,679 physicians. Notice, it's 679, not 680 or 81. This was a study. These physicians said Luckies are less irritating. L&M filters are just what the doctor ordered. We look at these advertisements now as a bizarre concoction. How could this have been? Well, it was. And now we look 50, 60, 70 years later and saying, oh my God, this was really bizarre. Now, I look back, you were denoting General 1976. I look back 50 years. What was the world like 50 years ago? I'm a mountaineer type guy. I enjoy the mountains, I enjoy climbing. So one of the big happenings 50 plus years ago, back in 1963, was Americans on Everest. 60 years ago was the first British expedition, not the first British expedition, but the first ascent of Mount Everest. 50 years ago tonight was the first, you know what happened 50 years ago tonight? The first showing on network TV of A Charlie Brown Christmas. 50 years ago, civil rights, the campaign for civil rights in the United States began to unfold. 50 years ago, we started getting serious about manned spaceflight. 50 years ago, the attainment of a huge mountain in Nepal, the highest peak, was still the veritable stepping on the moon. The American Everest Expedition, May 1963, sponsored by 3 major organizations. Number 1, Eddie Bauer, right? They made great sleeping bags, great jackets. They were in on it. The second major sponsor, National Geographic Society. They wanted their flag. They wanted the pictures. The third major sponsor, American tobacco companies. And in fact, there was a quote from '63. The smokers on the expedition were horrified to discover that instead of the expected 60,000 cigarettes in their cache at base camp, there were only 6,000. And everyone knows, let's be honest, folks, that you can't climb a mountain on that little nicotine. So that's only 50 years ago. What an aberration. Things changed 50 years ago. January 11th, 1963, 1964. a year and a half after President John F. Kennedy had established a committee to look at smoking as an issue. The committee sat around, year and a half, looking at literature, sitting there. There's an infamous photograph taken of their sessions. Oddly enough, on the table were ashtrays. Kid you not. Luther Terry, who was the Surgeon General at that point, was himself a smoker. And yet in the midst of this, after a year and a half of study, a report comes out. And a report, I dare say to you, that did change the world. Released in January 1964. What did it say? It identified smoking as a cause of lung cancer in men. Its conclusion was so subtle in its language. And I actually, first time I read this, I thought to myself, well, you know, this is typical governmentese, isn't it? But actually, I love the way it was put, because the final conclusion was cigarette smoking is a health hazard of sufficient importance in the US to warrant appropriate remedial action. So for 50 years, appropriate remedial action, in essence, changed the world. January 11th, Admiral Cowan mentioned, we were at the very moment the report was released. And I got to tell you how this report was released. It was released on a Saturday. 50 years later, it was also a Saturday. It was released at the State Department, where the press was brought in behind closed doors. Now, mind you, this is in an era when what? When smartphones weren't available. Right? You had to go as a reporter to a telephone. They didn't want anybody to telephone this report in until they had all the information. They locked them in a secure room at the State Department. They issued the findings of the report. They then said, tell the world, but they did it on a Saturday, fearful that the stock market would collapse. This would allow people to readjust their focus by Monday for the industry to sort of say, oh my God, something big happened. 50 years later, we're at the gravesite of Rear Admiral Luther Terry, former Surgeon General of the United States, buried at Arlington National, denoting that it's not just that one person, it's a movement that sprung from that report. So with the issuing of that report, we changed the movement. Right? We changed the idea that since then, the Surgeon General's office has been intimately involved in the issue of tobacco. 32 Surgeon General reports over the subsequent 50 years, looking at heart disease, COPD, cancers, pregnancy complications, pediatric diseases. The key reports that have been issued: women and smoking, involuntary smoking, the secondhand smoke issue, nicotine as an addictive product. Surgeon General Koop, the person who commissioned me as a young lieutenant, issued a 25-year of progress report. I was channeling him to a large extent 25 years later. How lucky I am as a career officer 25 years later to issue the 50th anniversary report. Young people, racial and ethnic minorities, biology, behavioral basis, 50 years of progress issued in 2014. And what do we issue this past year? This 50th anniversary report released at the White House a week after the 50th anniversary at Luther Terry's gravesite. 5 years of work, 85 authors, 120 reviewers, 983 pages. Lead authors, Dr. Jonathan Samuth from USC, Dr. Terry Pahacek, Ms. Leslie Norman from the CDC. This report covers 3 major topics: historical and trend information on tobacco use over the last 50 years. New findings. It's not just a look back. We still find out that this really is really bad for you. Call to action. How do we end this continuing tobacco use epidemic? And in essence, with a lot of anger in our voices, saying, you know what, after all these years, enough is enough. People are dying needlessly from an optional thing. So, in deference to David Letterman, here's my top 10 list of what this report said. Okay, good news and bad news mixed into this. Over 20 million premature deaths since the first report issued. We still have 480,000 annual deaths, preventable deaths, in the United States due to tobacco-related diseases. It remains the single largest cause of preventable disease and death in the United States. We look at the statistics. We saved 8 million lives since 1964, but 20 million lost. At this point in time, 45 million smokers, 18% of the US population. Last week, CDC announced we're down below that now, 17.9%. We're headed in the right direction, realizing that back in '64, 43% of our population were smokers. Look around you. 50 years ago, half of you would probably actually be smoking in this room at this meeting. The other half who weren't smokers wouldn't say a word because the concept of secondhand smoke still hadn't been really fully developed. How is it affecting my nation, a nation that I love? Economic burden, $289 billion a year of direct and indirect costs associated with tobacco use. Point number 2, I gotta say that there are enemies out there, and I am bold enough, maybe as an acting Surgeon General I'm bold enough, to say the tobacco epidemic was initiated and sustained by the aggressive strategies of the tobacco industry, which now is working worldwide, right? International guests, they're out there, which deliberately misled the public. They spend $1 million an hour to market their deadly and addictive product. They spend $27 per person. Tobacco control programs spend $1.50. That's what we're up against. The cigarette today is engineered. We have our friend from FDA, Rear Admiral Ashley, going to be talking with us soon. We know that smokers have a greater risk of developing lung cancer even though they smoke fewer cigarettes. This is a deadly product. Point number 3, we started with lung cancer in men. We now know it causes diseases in nearly all organs of the body. Diabetes associated with smoking, rheumatoid arthritis, colon and rectal cancer as a new finding of our 50th anniversary report. We now have 13 cancers. 1 in 3 cancer deaths are associated with tobacco. Erectile dysfunction, we see the commercials on every night associated with tobacco use. Macular degeneration, cleft lip palate, ADHD, brain development in the fetus. 6 million suffer from at least one smoking-related chronic disease. Point number 4, secondhand smoke causes cancer and preventable diseases, can affect infants and children. Of the 20 million premature deaths in '64, 2.5 million were in non-smokers. Stroke is now a newfound finding, a consequence of secondhand smoke. Point number 5, my high-risk group. Smoking in women, there used to be a commercial out there. Many of you may remember this. Virginia Slims, you've come a long way, baby. A sexist statement. It was sort of meant to say, well, look how you can advance. The reality now we have smoking in women risen sharply over 50 years. Now women are as likely to die from smoking as men. Lung cancer risk is the same as men. More women die from COPD than men. Ectopic pregnancy, reduced fertility as an issue. Point number 6, other effects. Inflammation, impaired immune function. Reduce the body's ability to fight off infection and disease. Look at TB, death associated with smoking. Point number 7, although we've seen declines, we still have major health disparities in my own nation. Race and ethnicity, educational level, socioeconomic status, regions of the US. I know the Midwest and the Southeast are my hotspots. Sexual orientation, mental illness, increased rates associated in some of those subpopulations. Point number 8, I know what works. Tobacco control programs and policies are effective. We need to be able to support them and fund them. So what works? Smoke-free indoor protection. Right now, only half the US population has protection with indoor air smoke-free laws. We got to raise the average excise cigarette taxes. It's a simple formula. Price goes up, use goes down. We have to fund statewide tobacco control programs at the CDC recommended levels. Hard-hitting, high-impact media campaigns, as FDA and CDC is currently undertaken. It is an addiction. We have to realize that you get addicted to this nicotine. Tobacco use cessation treatment for all smokers. Effective use of the FDA. It's a new power within FDA, 5 years old, that they play a role in this. Expanding control and prevention research efforts is part of the control measures. Point number 9, in the youth, The burden of death and disease from tobacco use is overwhelmingly caused by cigarettes. Every day, 3,200 kids in the United States under the age of 18 smoke their first cigarette. Every day, 2,100 become daily smokers. We know statistically that 98% of all adult smokers started before they were 26. 90% before they were 18. I know the population I need to affect here. If I let my current statistics saying, oh, we're down to 18%, that's good enough, 5.6 million kids now alive will die prematurely from smoking-related diseases. The goal is to make the next generation tobacco-free. And the final point is, we've been at this for 50 years. People say, well, what a waste of taxpayer money. You know, you should stop. No! I'm a public health person. This is the #1 preventable disease, cause of death. We won't stop until it's over. We won't stop until we have our numbers down to 0. So what's the vision? The vision is that someone else will be in this uniform 25 years from now as a Surgeon General at the 75th recognition of this. By then, I need to have numbers that are zeros in certain parts of my population. I'm not naive enough to say it's all going to be over. Certainly at the 100th anniversary, 50 years from now, what I want is I want a historical look backwards. I want to look like we now look at smallpox, saying, oh, look at these interesting pictures. What a bizarre world where we used to allow this. Think about how our world has changed in these 50 years. It's a simple process of change, right? Can you smoke on airplanes anymore? No, that started, I think, in 1991. DOD no longer offered cigarettes in their K rations. I think it was 1985. The White House went smoke-free, maybe 88. The world has changed. Do you see ashtrays on your table? Do you feel comfortable lighting up in this room in front of your peers? You may do it outside, some of you. But I dare say our world has changed to such an extent that if I pulled out a pack of cigarettes right now, as an acting Surgeon General of the United States, and I lit up in front of you, in a few short hours, there would be a former acting Surgeon General of the United States. That's the impact, folks, of how we can change the world. So thank you so much for listening to me. Thank you for supporting me. As of January 1st, 2014, the U.S. Public Health Service, this small unknown entity of the U.S. government, has become the first uniformed service of the 7 uniformed services in these beloved United States to go totally smoke-free and e-cigarette-free and tobacco-free while in uniform. Now I'd like to introduce one of my compadres in all this, and that's Rear Admiral David Ashley. David's with our Office of Tobacco Products within the Food and Drug Administration. Knock 'em dead, David.
Over the years that I've spent in the public health service, there are some hard things I've had to do. No question, one of the hardest things I've ever had to do is follow Rear Admiral Lushniak in presenting. But I will give it my best shot. I'm Rear Admiral David Ashley, and what I'm going to describe for you guys today is efforts we have made to improve the health and to support the readiness of officers within the public health service by helping them become tobacco-free. As the Acting Surgeon General has pointed out, we're well aware of the adverse impact that smoking causes, including the fact that nearly half a million premature deaths occur every year. More than 87% of lung cancer deaths are due to smoking, 61% of all pulmonary deaths, 32% of all coronary deaths. And there's also a huge cost, a health cost to smoking, both to individual users and to the population. Smoking causes enormous costs to our economy. In addition to cancer, which most people are very well aware of, which occurs after a long history of tobacco use, smoking has a more immediate effect on the ability of users to be fit and healthy. Smoking takes away a person's breath, through chronic obstructive pulmonary disease. Those rates have risen steadily since 1964. Nearly 8 out of 10 COPD deaths are from smoking. They also have a higher risk of lung cancer and heart disease, and women are now dying from COPD in the same numbers as men who smoke. Smoking also impacts the fitness and health by damaging the heart. Cardiovascular disease is the biggest killer in the United States, and smoking is a major cause of cardiovascular disease. But the good news is that cessation leads to better health outcomes. Quitting smoking at any age in life improves life expectancy, and smokers who stop see an improvement in health very quickly after they stop use. The earlier they stop, the more of an improvement they will experience. So if you stop at the age of 30, you recover about 10 years of life expectancy. Even if you stop at the age of 60, you can still recover some years of life expectancy. So that's the good news. Until the issuance of the first Surgeon General's report in 1964, adult per capita consumption of cigarettes rose pretty steadily in the United States. The most rapid increases occurring during periods of major wars such as World War I and World War II. The provision of free cigarettes turned many into addicted smokers who've had to battle that resulting disease for a lifetime and created a culture of smoking. In June 2013, the Assistant Secretary for Health issued a directive that all active duty U.S. Public Health Service Corps officers shall not use tobacco products while in uniform. And this included cigars, cigarettes, electronic cigarettes, pipes, water pipes, hookah, smokeless products that are chewed, dipped, and snuffed, the whole variety of tobacco products. In order to help officers, the Acting Surgeon General directed that a group be formed to help provide support for the officers who wanted to use this directive as an incentive to stop tobacco use. To carry out that directive, 4 working groups were formed. These included one to do a tobacco use survey so that we would understand the current status of tobacco use among USPHS Commissioned Corps officers. A content group to identify recommended tools that officers could use to improve their likelihood of success. A resources group to identify support resources available to officers, and then a communications group in order to develop materials to be used to communicate the tools and support resources out to officers to improve their likelihood of success at tobacco use cessation. First thing is the survey. And we found some very interesting results from that. We found that 41% of officers had used tobacco at some point in their lives, but only about 7% were current users. That's significantly lower than the national average. Use of cigarettes and cigars were about the same. There was some use of other products such as e-cigarettes or water pipes, but these were very limited. The vast majority, as in the normal population, are using cigars and cigarettes. The survey also found that about half of current cigarette smokers had tried to quit in the past year. And this is very common. Most people who use cigarettes want to quit and try to quit. They've tried using a variety of strategies, including switching to other products, use of counseling, using replacement products, and the use of prescription medications. One of the things of note is that 45% of current cigarette smokers indicated they wanted to quit use of all tobacco for good. The survey also evaluated current users' awareness of support resources such as TRICARE, quit lines, and other workplace resources. The awareness of these resources was much less than optimal. It indicates a possible area that we could really do some improvement in. So, these tobacco cessation groups came up with 4 different areas of concern and 4 areas where we would put out information. First was 10 key guideline recommendations. Second was information and education on what to know when seeking treatment, particularly on the types of interventions that are available. The third was what the officers ought to know when they seek treatment, the components of what an intensive intervention really should be. And then finally, a list of places to go to get help, tobacco cessation programs. So recommendations focuses on the advice for clinicians primarily, but it's also as a means for individual users to know if they were getting the most effective support from their clinician. The recommendations included the fact that tobacco addiction is a long-term disease and it often requires repeated attempts to stop. Clinicians and healthcare delivery systems should consistently identify and document tobacco use status and treat every tobacco user seen in a healthcare setting. The third, clinicians should encourage every patient willing to make a quit attempt to use the recommended counseling treatments and medications. Number four, clinicians should offer every patient who uses tobacco at least the brief treatments shown to be effective in the guidelines. Number five, individual group and telephone counseling can help, and the amount of help increases with treatment intensity. The sixth thing is clinicians should encourage all their patients to use known effective medications when trying to stop smoking, except then when this would be harm to the patient or with specific groups of people where there isn't enough evidence to support that. And there are 7 first-line medications that have already been shown to increase smoking abstinence or to impact long-term smoking abstinence rates. Clinicians should consider use of certain combinations of medications where that's appropriate. Counseling and medication can help when used by themselves for treating tobacco addictions, and people should be encouraged to use both cessation and medication, or cessation counseling and medication. The telephone quit line counseling can help with many people and can reach many. Therefore, both clinicians and healthcare delivery systems should make use that people are trying to quit can contact quit lines and give them that information so they know how to get to them. If a tobacco user currently doesn't want to stop using tobacco, clinicians should use the motivational treatments that the guideline describes to try to help people, to encourage them to stop use. And then finally, tobacco addiction treatments help more often, cost less compared to actions taken to help relieve other clinical disorders. So insurers and purchasers should ensure that all insurance plans include counseling and medication that have been shown to help in the guidance as covered benefits. We also included some descriptions for the officers so they would understand better what they might expect. And that includes the types of interventions that might be involved, including minimal intervention, a brief intervention, motivational interviewing, and an intense intervention. And this was available again to help officers understand what they might be taking on, so that officers will be aware of what to expect from intensive intervention. A section of the content describes the components. It includes strategies for the intensive intervention, the components which include assessment, program clinicians, program intensity, the format, types of counseling and behavioral therapies, medication, and the population. And then we also include where officers can go to get help. Again, the survey really showed that there was less than optimal understanding of where they can even go to get help. So this actually, to me, is a very important part of the message we're giving out to officers. So it talks about individual and group-based cessation programs, then group-based tobacco cessation programs, quit lines, tobacco cessation apps and social media, and helpful tobacco cessation websites and publications. We expect to have this available too on the USPHS Commission Corps website very soon as a resource for officers. The recommendations, information on interventions and cessation programs have been carefully vetted and reviewed. The information reflects the current clinical practice guideline and should be applicable to all branches of the service. We're glad to share any of this information with any of the other uniformed services, and I recommend that you look at this carefully and see where it might be incorporated into your services also. The material was developed by a cadre of officers from a wide array of disciplines and agencies. Expertise included health service officers, pharmacologists, clinicians, engineers, scientists. Virtually every organization within the USPHS where officers serve were represented. That's the list of the other 2 subgroups. So thank you.
Nice job, David. And you know, part of this theme is, you know, once again, I know there's great progress being made in DoD. To our international colleagues, you know, this is an incredible battle ahead of us. The reality is, though, we had the same feeling 50 years ago when people talked about, you know, not having advertising on TV, and when we talked about the idea of airplanes going smoke-free. We talked about, you know, the aspirational model. You know, once again, I remind you that with programs like this, with that will and that desire, and in fact, the symbolism that exists out there, right? When in uniform, I portray something to my own nation, to the world. We portray something. And the sense is, I need to have the sense that while I wear this uniform, I denote a service to my nation, a focus of my mission, and that I'm a healthy and fit individual. And what doesn't fit? This doesn't fit in uniform. One of our activists in this, and I mentioned the fact that we are in 26 different departments and agencies of the US government, and yes, we've embedded ourselves within the Department of Defense. They wanted us. It's not like we just snuck in, Dr. Woodson, so thank you for wanting us. It is Captain Ellenberg. And Captain Ellenberg has been a quintessential leader within DoD in terms of health and fitness and being our rallying point for infiltration on the tobacco issue. Captain Ellenberg.
Thank you, sir. I started out in DoD, actually, before I went over to the US Public Health Service. I grew up in an orphanage, and when I graduated and I left the Milton Hershey School, the orphanage where I grew up, my family stayed in Hershey, but I got a new family in the military, and I think that's an important point that I want to start off on. When you come into the military and when you deploy, the lines between family and those you deploy with blur. You care about the people you deploy with like they are your family. And because you care about them and because you love them, you know that you have a moral obligation to help them be as healthy as they can be. So in the Department of Defense, why is tobacco a really big problem? I'll answer that in a minute. And the question is it a big problem? I think that's the first thing we have to decide. Do we have a problem here? And we just got done seeing nationally what the problem is for the country. But let's talk about the operator in the field environment for a second. For those of you who have been deployed, you know that your night vision is incredibly important to you. For those of you who have deployed, the ability to smell may save your life. Think about being on patrol. Your ability to be physically fit, to perform, is incredibly important. Whether you're humping a big ruck, whether you're running a particular scenario. And even for our submariners, it's really important. They're some of our most dedicated folks that really provide a lot of national security. One particular group of them that I worked with, 67% of them were at risk for losing their ability to deploy simply because they were overweight and they were using spit tobacco. And the physiological effect of spit tobacco, along with a little bit being overweight, put them at risk for uncontrolled hypertension, high blood pressure. That's a huge loss. They've worked really hard to be in the position they're in, and we need them. And so I go back to the moral obligation that we have to help address tobacco. We already talked about how it fits into the bigger picture. So one of the things our Secretary of Defense did was he asked us, he said, you know what? We need to do a review of our policy. Help me define the problem, help me think about options, and let me then make some decisions for the Department of Defense on a way forward. So we're currently going through that process now. We are really working hard to achieve a balanced approach. The people that we're trying to serve are the people that are serving us, right? They're defending our nation. our country here was built on the idea of independent liberty, right? I have my rights. I'm defending my rights. So if I have individual rights, who are you to tell me what I can or cannot do, right? There's a little bit of a friction there. And that exists often in public health. And so when we looked at options, what we wanted to do was make sure that whatever options we came up with, number one, led to greater education, so that folks really did know the impact it had on their performance when they deploy, because they care about how they can help their buddy. Number two, they care about the impact to their performance later in life as well. So we wanted to really include that, but we wanted to balance the right of the people who use tobacco and the right of those not to be exposed to secondhand smoke or exposed to spit on the pool deck or things like that. So we really thought long and hard about the options. The other thing we did was we said, what kind of tobacco are we using? This is a chart broken down by age. So the blue is 18 to 20, that's the darker blue. Then 21 to 25 is red, and 26 to 65 is in the orange. The yellow dotted line is the national average. And you can see in general, we're well above the national average, both in smoking, but even more so in smokeless tobacco use. And there's not a huge amount out there on addressing smokeless tobacco use, but we know that it really does impact performance. We've been working with special operations forces to really take a look at the impact to performance and what alternatives there are. So why do we have this discrepancy? Why are we so much higher? Does tobacco use really relieve stress? Because a lot of people adopt it thinking that it does. It doesn't. When you're out in an operational environment and you can't get that nicotine stimulation, it actually creates more stress. So then why this difference? Well, probably one of the biggest things is a cultural thing. If you are in a sleep-deprived environment, it actually is perceived to save your life. If nicotine helps you stay alert, at that moment, it's saving your life. They're not looking at it like the national public and saying, oh, there's no good in this. They think that there's good because it saves their life. So that's, again, why we're working with Special Operations Forces and the Olympics and other folks who really look at performance and who have to function in sleep-deprived environments to say, what are our alternatives? So one of the things the Army has done is they've put out something called the Performance Triad. They're looking at how do we create an environment that keeps people alert under regular conditions. And that's great, and there's a huge focus on sleep hygiene, eating right, and exercising. And then in the operational environment, the Special Operations Forces are looking at caffeine dosing, because you can get the same alertness, but the physical impact is not as great as tobacco use. But that takes education. And so right now, if we have non-commissioned officers who are going into that environment, telling people, you might want to use some tobacco to stay alert, we've got to give them alternatives. We have to think about that. We have to re-educate them. Again, going back to not about that this causes cancer, not that it causes heart disease, they know that, but about what they care about in the moment. It affects your eyesight. It affects your sense of smell, the things that they need to survive. It's also important to us because in our country, our funding comes from discretionary funding. And as you can see from this chart, the discretionary funding available to the Department of Defense continues to grow smaller. And so the great question we get asked is, if we're spending $1.6 billion in tobacco-related medical care and lost productivity, can we change that number? Can we change that cost to DoD? This is secondary to health and performance, but it's still an important consideration. One of the concerns we get back when we start talking about tobacco in the Department of Defense is, oh, geez, if you take away my tobacco, are you going to touch alcohol next? Are you going to touch the Twinkies the food that you sell next. And you know what? We are thinking about the food, not necessarily that we sell, but we certainly are taking into consideration the fuel that we're giving our service members. We want to improve that for sure. We do talk about alcohol. You know, none of you out there have any beer or wine right now. It's just not appropriate, time and place. But those don't have the same health impact that tobacco has. Tobacco is the only thing that if used as prescribed will kill you, right? So this is an important topic. You know, in order to make traction and get buy-in for making a difference and making a change in tobacco, we really do have to differentiate tobacco from other products. We thought that it would be important to see what are the thoughts of our active service members. If we were going to actually come up with policies that would limit tobacco use or help control tobacco use among our service members and our DoD community, we thought it was important to know what the people said. So we have a system called the information, having a brain cramp, sorry about that. The Interactive Customer Evaluation System. It's available on all our installations, and people put in information, comments, whatever they want. 96% of the comments received on tobacco between last January and June, unsolicited, expressed concern about secondhand smoke. In particular, as we have more energy conservation and we open our windows, that secondhand smoke is coming into office buildings. It's coming into the barracks where our folks sleep. And we know the scientific impact of secondhand smoke. We look at the cost of moving signs to increase tobacco-free areas, maybe $200, $700 or something to move a sign. But if you look at the amount of emergency department visits due to asthma, something specifically irritated and aggravated by secondhand smoke, the costs far outweigh the cost of moving the distance where people do use tobacco. Some of the complaints that came in from active service members were that they requested additional breaks. They said, this stuff's addictive. We need more breaks. We know it affects productivity, but this is really hard. And many of them don't want to use tobacco anymore. So what was our strategy for developing the options? We certainly went back to the CDC's best practices for comprehensive tobacco control programs. We leveraged the National Prevention Council that was initially made up of 17 federal agencies. I have very good working relationships. You know, the Admiral and I had met on the phone, Admiral Hunter out there. I mean, all over the place. What can we do to help? We are now taking it all the way to the Joint Chiefs of Staff. So we talk to the OpSteps tanks. We meet with the Joint Chiefs of Staff on Friday. We're getting input from our civilian leadership, all of the undersecretaries, our DepSecDef. We're not making a decision on what is best for the Department of Defense in regards to tobacco without gathering information first, without taking into consideration why we're using it, and without coming up with options that are going to support folks once they stop using it. I just wanted to show you, when we put together the Defense Advisory Committee, we had representatives from everywhere. This included legal. This included the unions, not the unions themselves, but the government representative on behalf of the unions. This covered the exchange representatives. Many of you know that the money we get from morale, recreation, and welfare comes from the money sold that we get back. Some of it comes from selling tobacco. So how do we address that? We don't want those recreational activities to go down. But in fact, on the installations, the Navy installations and the Marine installations, where they stopped selling tobacco at a reduced price, their impact was mitigated. It was less than on the Army and Air Force installations where tobacco was still sold at a discount. So it didn't change the behavior necessarily of purchasing tobacco from people who are already addicted. Therefore, by not selling it at a discount, it actually mitigated some of the loss to MWR. So that was a good thing. So we're looking for these strides that we can make that help send more consistent messaging. We certainly can't say, don't use tobacco, it's going to affect your eyesight, it's going to affect your sense of smell, but wink, wink, we're selling it at a discount. So hopefully that's something we can address. So in summary, we've identified a lot of options. I'm not going to go through what those options are out of respect for our tanks and out of respect for Secretary of Defense. We'll present him everything from do nothing to do everything, and they will come up with a decision on what is best for our department. How do we know when the work is over? It's not. Anytime we do public health, anytime we do anything, it's a long relay race. It's iterative. Think about yourself, right? Think about your military and your military's capabilities and capacities. You continue to improve them over time, your surgical techniques, right? A lot of different interventions. They say if you want to learn something, look back in history. I think some of that's true. When we are treating Ebola right now, some of the best outcomes are coming simply from providing great hydration and watching electrolytes. It's not necessarily from the fanciest things that are being done. We have a pretty good survival rate at the site set up by the U.S. Public Health Service, and that'll be interesting to see come out. Likewise with tobacco. You just have to look back in history. We know what's effective. We have an opportunity to employ it, but we have to be sensitive to our culture. That's all I have to share with you today. I just am very, very excited and honored to be a part of this. Like I said, I consider the military my family. I don't have a lot of family, but those are my brothers, those are my sisters. They've had my back. I want to have their back. And at the same time, while I do that, I want to respect the reasons why they're initiating tobacco use and provide support to them in other ways. And when I say I, it's really representative of our entire community, the entire Department of Defense military health system, and the leaders that I showed on the Defense Advisory Committee on Tobacco. Thank you very much.
So thank you, Rear Admiral Ashley. Thank you, Captain Ellenberg. And special thanks to Admiral Cowan and to the program committee for allowing us to be the lead plenary. You know, this is an anniversary year, so I can't promise that we'll be invited back for the 51st anniversary of the Surgeon General's report. An anniversary year allows us to come and celebrate, commemorate, reflect on what once was, and to reestablish aspirations for what can be. Now, is all this doable? We've already seen progress, right? Within the Department of Defense, you know, the Army's Public Health Command has gone tobacco-free on their campuses. You know, that's a step forward. Certainly looking at, you know, the Army, the Air Force, the Navy, medical facilities, you know, 80, 90% tobacco-free. Our Coast Guard friends have gone from a smoking rate of 30% down to 20%. We're headed here, folks, in the right direction. And whether it's the 51st year of the Surgeon General's report on smoking, the 52nd, the 55th, the 60th, let's reaffirm the fact that this problem is not just going to go away by itself. In the United States, as I mentioned, we're down to 18% smoking rate. The goal is attainable. This becomes a further concerted battle. We look at the hot spots that exist out there. We look at our ability to change the way people view smoking and tobacco use in this country, the way we've already changed our social norms, and we remain optimistic that in that 51st year and 52nd year and 60th year and 70th year, that the goal that we have is a bold and noble goal. It's a goal that will save lives, will save precious resources, and will make not only our nation a healthier and fit nation, but the world a healthier and fit world. Thank you for being part of this session today. And now, ladies and gentlemen, it's my pleasure to introduce the good Admiral Cowan.
Wonderful.